Hi, good afternoon, and welcome to the Healthcare Partner Nevada Doc Talk on advanced care planning. My name is Nicole King, and I'm the Director of Broker and Community Relations at Healthcare Partners. Our team typically hosts and attends in-person events to connect with our Southern Nevada community and share the exciting things we're doing as an organization to care for our patients. Although we're not currently able to connect with you in person, we're thrilled to have launched virtual events to connect with you from the comfort of your home. We appreciate you joining us today to learn about advanced care planning from our Medical Director for High Risk and Advanced Practice Providers, Dr. Bob Vadovic. And with that, I'll turn it over to Dr. Vadovic.
Hi, thanks, Nicole. Welcome, everybody. We appreciate you joining us. I just wanted to introduce myself. I am Bob Vadovic. I am a nurse practitioner and medical director for our APPs here at the organization. I wanted to talk to you today about advanced care planning, something that is very important to us here at Healthcare Partners. We believe that we should be honoring your wishes when something happens or if you end up hospitalized. And so we want to make sure that all of you have in place plans or wishes for what you want done should you not be able to take care of yourselves. So advanced care planning can be very crazy. It is all over the place for some people, and they just don't know what to do or where to start. And so hopefully this talk will be able to give you some instructions on how to do that. So first, what is advanced care planning? Advanced care planning goes into a number of different things. Most people think of advanced care planning as a living will or an advance directive, and those documents will usually tell you what to do in an emergency if you weren't breathing or if your heart stopped beating. But they can be a lot more, and there's a lot more to advanced care planning than just your health decisions. A number of things should be thought of: living arrangements, who you're going to live with long term if you're unable to take care of yourself. How are you going to obtain food? Many insurance companies don't have that capability, but some do. And so procurement of food is important to think about. Who's going to help you with your activities of daily living, your toiletry, your showering, your bathing? That's all necessary to think about when you're looking at advanced care planning. Who's going to help you take your medications? Many patients take a lot of different medications. It becomes very confusing. And so sometimes people need help with those medications. Travel arrangements, if you need to go visit family, if you need to go out of state to seek medical treatment because the doctor is not near you. Who's going to help with your finances? Those are all things that you need to discuss or think about when you are doing advanced care planning. So the scope of advanced care planning is vast. Medicare spends about a quarter of the dollars they spend on people within the last 12 months of life. And what that shows is that there's just not an adequate amount of advanced care planning. We are doing more and spending more on patients as they're preparing to die. And we want to make sure that that time that you're spending in those last few months of your life are spent comfortably in the way you want it to be done. 40% of patients have no documentation at all about what type of advanced care planning they want done. And very rarely is palliative care or hospice ever ordered. Most hospice referrals, and I don't remember the exact statistic, but it's upward of 50% of hospice referrals come within the last 2 weeks of life. Hospice is intended to and works best if you get them on earlier. And there are 4 patients that have 6 months or less to live. So earlier hospice referrals do work out better for the patient and the family, and we're not seeing that as a rule of thumb. So just a little humor here. We should talk about our final arrangements so the kids aren't burdened with it. Why should we care? That'll be their problem. Right, well, at least we talked about it. And this is something that I see a lot, where people just don't talk to their families about these decisions. They either don't want to burden family or they just don't want to talk about it. These are very personal, sensitive conversations, and a lot of times patients just don't want to have them. So it becomes very taboo, if you will, but you got to have these conversations. So from a patient's perspective, and this is a real patient in the past, somebody who did not have an advance directive on hand. It was an 82-year-old male who had COPD, or chronic obstructive pulmonary disease, from smoking his entire life. He wrote an advance directive several years ago that stated he did not want to be resuscitated or did not want to be on a ventilator. Unfortunately, the document was never witnessed or notarized, and he never talked about it with his primary care provider. He never brought a copy into the primary care provider's office, so they didn't know anything about it. The patient ended up hospitalized with difficulty breathing and ended up being put on a ventilator. Because of the severity of his disease, they were unable to get him off the ventilator easily, and he spent 80 days in the ICU on the ventilator. Unfortunately, during that time frame, you're also going to have to put a tracheostomy in the patient. You're also going to have to put a feeding tube in the patient. All things that, based on what he said earlier, he probably didn't want, but nobody knew about. After 80 days, somebody woke him up from the ventilator just to make sure see how he was doing, and they asked him about his do not resuscitate. He was able to shake his head and say, yes, I do not want this. And they pulled the ventilator, they placed him on hospice, and he died peacefully later that day. But you could have avoided a very serious condition, 80 days in the ICU, a tracheostomy, a peg tube, all if he had talked about this with his primary care provider and his family. So what does this cost? When we look at this, we look at cost of healthcare overall and what it means to the patient. So the cost to complete an advance directive or a pulse is $0. It doesn't cost anything to talk to us and complete it. The cost of an 80-day admission to the ICU is about $1 million. The cost for the hospitalist to wake up the patient off the ventilator and have him nod his head to confirm his DNR is priceless. We want to make sure that we are delivering the care that you want. We don't want to be giving care that you don't want or that you're going to be unhappy with. You're the patient, you're the one that's going through this. We want to make sure your wishes are honored. And the best way to do that is to have an advance directive. So what about the advance directive discussion? Who do we have it with? When do we have it? So the discussion should occur at any time. You can be of any age and start having this discussion about advance directives. The younger you are, the earlier you have the conversations, the better it tends to be. You do have to consider, though, if you do it earlier in life, you want to review it every few years and make sure it's still what you want. Who to discuss it with? Discuss it with everybody. You want everybody and anybody you know that may be involved in your care to know what you want done in the future. You have to let your primary care provider know. Ultimately, they're the ones that are going to be making decisions for you if you end up in the hospital. And you need them to know what you want. Who should be in charge? I have this discussion a lot with patients. The person that you want in charge of your medical decisions is the person that is going to agree with your wishes. You don't want somebody that's going to tell somebody to do opposite of what you want. You want to make sure that they're following what you want. What are my wishes? Tell them, do you want to be resuscitated? Do you want to be on a ventilator? Do you want feeding tubes? Or do you want nothing? And all of that is acceptable, but you got to make sure your decision maker knows about it. Keep your advance directive in a safe place, but you also want to make sure you keep it in a place where you know it is and others know where it is. They want to be able to access it should something happen. You should always give a copy to your primary care provider. I would also tell you to always give copies to any specialist that you see. This way, if anything does happen, a lot of people have it and they can access it easily. Why do I need one? Again, we discussed this. You need one simply to tell us what you want done. We don't want you to be uncomfortable. We want you to be peaceful, and we want you to be have done what you want done. They're used whenever you can't speak for yourself. Anytime you're in a situation where you can't give us instruction, whether it be from an altered mental status to being unconscious to being in a cardiac arrest, we would use an advance directive. So there are different types of advance directives. The most common one that people know about is the Advance Directive or the Living Will. That is a document that you can spell out anything you want it to say. It could be as simple as "do not resuscitate me" to as complex as 5, 6 pages. A lot of people have these written out by lawyers. Personally, that's not my recommendation because it becomes difficult to read and understand in the healthcare setting. Simple language, plain language is fine as long as it's notarized and witnessed. It's a legal document. Tell us what you want done. If your heart stops beating, if you're stop breathing, how long do you want treatment for? How long do you not want treatment for? What kind of treatments do you want? It could be as simple as "do not touch me" to as complex as "I want to be cryogenically frozen until they find a cure for my disease," and anything in between. There is a PULSE, and we'll get a little bit more into the PULSE, but the PULSE is a provider-ordered life-sustaining treatment document. This is an order signed by a provider. Most states have them in effect at this point, and they're very simple documents to understand and read. One of the issues with an advance directive is they can be very lengthy, and they're not easily understood or read during an emergency situation, where the PULSE is very easy to read. So if you don't want to be resuscitated, it's very easy for either EMS or the emergency room to say, "Oh, this patient doesn't want to be resuscitated, let's leave them alone." The healthcare proxy is a document. It can also be a part of your advance directive or a living will that designates somebody to make decisions for you if you're not able to. The healthcare proxy is there to decide what you want done in the event that your document does not cover the situation. So if you are on a ventilator and they want to put in a tracheostomy or they want to put in a feeding tube and you never address that in your advance directive, that's when the healthcare proxy would make a decision. The healthcare proxy is not to replace the advance directive, and they're not to supersede the advance directive, but they're there to address issues that you haven't addressed in the past. And then the durable power of attorney is also a separate document, or also can be a part of your advance directive, which designates somebody to make decisions for you outside of healthcare. So financial decisions, living decisions, things like that. And all of that can be as one document or as individual documents. So as far as an advance directive goes, some areas that you do want to include in your advance directive when you're thinking about it or writing it out is, do you want to be an organ donor? Do you not want to be an organ donor? Who is my healthcare proxy? What kind of healthcare decisions do I want to make? Do I want CPR? Do I want a ventilator? Do I want to have a tracheostomy or a feeding tube? Do I want IV nutritions or fluids? Do I want antibiotics? Do I want medications? Or do I want to be put on hospice and left alone and be comfortable? One of the options that we use in Healthcare Partners, as well as many places around the country, is a 5 wishes document. This is a document that's already pre-filled out with blanks in areas where you need to put specifics. You sign it and it's witnessed, and then it's considered a legal document. So it's very easy to use, and it's a good tool to keep on hand if you don't know how to start one or what to put in it. As I mentioned, there is the PULSE. This is an order signed by a provider. Because it is an order signed by a provider, it is honored by all healthcare providers. It's very simple. It says, do not resuscitate or resuscitate. It gives brief descriptions about what your wishes are. It is legally binding, and it is very easy to understand. So if EMS shows up and they see this, they're going to read this and honor what you want done. We recommend, if you fill this out, that you keep it in a place of prominence. We recommend either on your headboard or on the refrigerator where it's seen easily. You can also register both an advance directive and a PULSE with the state, and the state keeps a virtual lockbox which can be accessed by EMS in the emergency room, and you would get a card sent to you that states you have a PULSE so that people know to look for it and they can access it if you can't speak or if there's nobody with you. This does need to be filled out with a provider. You can't fill this out on your own because it does need to be signed by the provider. If it's not signed by you and the provider, it's not a valid document. So what does having an advance directive look like clinically? So it is a seamless transition. When you have an advanced care in place, it means that we're delivering what you want us to deliver. There's nobody that I know of that wants to be in pain or be uncomfortable. And so we want to make sure we do what you want. As a provider, you are in charge as the patient. Me as a provider is there to honor your wishes. When we develop treatment plans, it's to be done with your decision or your thoughts in mind, and we need to come up with a treatment plan that works for both of us. This is no different. We want to make sure that we are honoring your wishes at the end of your life so that you're part of the treatment plan. Another little funny for you about advance directives. So again, the patient's perspective, the same patient we had earlier, let's talk about. So the 82-year-old male with COPD who goes to the emergency room because they can't breathe, again, wrote an advance directive in 2012 that says do not resuscitate, do not put on a ventilator. This time, however, that document was signed, witnessed, and discussed with the primary care provider, and they have a copy of it. So the primary care provider is called down to the emergency room because you're there. They decide not to put you on a ventilator because that's not your wishes. They treat you with supportive care. They put you on hospice and discharge you home. 2 days later, you die at home peacefully with your family around you. And I would be hard pressed to find somebody that doesn't want that type of situation for them or their loved ones. Again, what's the cost for this? $0 to complete the advance directive or the pulse. The cost of an 80-day admission was $1 million. The cost for the waking up the patient is $0. It's priceless again. So not only are we saving $1 million in healthcare costs, but we're saving you the pain, aggravation, and frustration for you and your family of having something done that you just didn't want done in the first place. So the role of family and friends in this process is very important. If you don't have documents in place, your family and friends are going to be the ones that are making the decisions for you. You have to make sure they know what you want. You can talk about it, and if they have a general understanding, that's okay, but you really need to be specific with them. The next of kin is always considered the decision maker if you're not able to make decisions. The order in which the next of kin is decided is first your spouse or significant, spouse, legal spouse, any adult children, then it goes to your parents, then siblings, and then any other relatives or friends. And this is very ambiguous at times. A lot of spouses don't want to make decisions because they're very close to their significant other, and they don't want to have to make those decisions. And so oftentimes there's arguments or discussions about what to do because it's difficult for family to get on the same page. And that's why you really want to make sure that they know what you want done. If your spouse or significant other is not on board with what you want done, if they say, if you want nothing done and you want to be a do not resuscitate and they don't agree with that, don't make them your decision maker. Make somebody else your healthcare proxy. You still love them, you still want them to be a part of it, but you want to make sure that somebody that is going to honor your wishes is the one making those decisions. So that's what I have on advance directives. I hope it helps. If you have any questions, please ask.
Thank you so much, Mr. Vadovic. We really appreciate it. Again, thank you everyone who tuned in today to hear from Dr. Bob. Hope you found the information helpful and useful. Have a good rest of your day, and we appreciate staying home for Nevada. Stay safe and healthy. Thank you.